We're going to talk about the path forward for healthcare reform, not a small topic at all. And so to do that, we're going to have a moderator who really makes a difference and who understands a broad perspective of healthcare and what that means on the path forward. So it's my pleasure to introduce James Springfield, who is the president of Blue Cross Blue Shield of Texas. And I heard some beginning applause, so if you wanted to applaud, you can do that. James was announced as the president in March and took that position in April, and so relatively new, but not new to the healthcare community and industry. In fact, before he was the COO at the Cancer Treatment Centers of America, and he also has 13 years of experience at Memorial Hermann Healthcare Systems in Houston, on top of many other features. So he's our perfect moderator today to get us started with these experts and the questions about healthcare and the path forward for reform. Thank you.
Thank you, and good afternoon. It's so good to be with you today. As we were walking in, I saw 4 or 5 people that I haven't seen in a while, familiar faces. Great to be here. I did spend most of my career on the provider side of the healthcare spectrum, and it only took me 35 years to make it into this more progressive group. So I appreciate being able to be with you today, and I think you're in for a treat. These 3 gentlemen that we'll introduce in just a minute are absolute authorities on health policy, what's going on, and they also bring a practical slant to their thought leadership. And so I look forward to you hearing their comments and hopefully a lively question and answer following. I'm going to introduce beginning immediately to my left, and we will, as we introduce, I'll introduce all 3, and then we'll start with James, and they'll make some opening comments and give you some of their significant background and some thoughts broadly on some key policy issues that we're dealing with today. And then we'll go in from there into a question and answer session. So it's my pleasure to introduce James Capretta, the resident fellow at American Enterprise Institute. Dr. Austin Fracht, health economist, director of the Partnered Evidence-Based Policy Resource Center at the Boston VA Healthcare System. Dr. Avik Roy, president of the Foundation for Research on Equal Opportunity and a frequent speaker as well. And so why don't you join me in welcoming these gentlemen. With that, James, if you would make some comments and tell us a little bit about yourself.
Sure. Well, thank you, James. Thanks to the conference organizers for having me again this year. I was here 2 years ago when this was last done in person, and so it is nice to be able to hold one of these again in person. So I'm glad to be here. As was indicated, I'm a senior fellow at the American Enterprise Institute. It's a think tank in Washington. So we think all day, but we try to also influence public policy through some of the things we publish and write and say. My career has been in healthcare policy, both in government and out of government, and I'm very pleased to be able to share a couple of thoughts about where I see things going at the moment. So, we had a big election a year ago, not just a week ago, but a year ago. And that did obviously change the big picture a little bit in Washington national policy on healthcare. And that tends to feed through to decision-making all throughout the country because, of course, the national government gets very involved in approval or non-approval of state plans through Medicaid and other things. So when the government and the control of political control changes in Washington, it does have an effect generally across the country in terms of healthcare policy. I'd say the way to maybe describe it is that when President Trump came in 2017, there was a little bit of uncertainty about the kind of policies he'd be pursuing in healthcare. Obviously, they had campaigned on repeal and replace, which didn't happen. But in general, what were they going to do about, what kind of philosophy did they have about improving healthcare? And I'd say it kind of took a couple years to fill in some of the blanks, mostly done through, frankly, HHS officials and also White House officials sort of filling in some of the, what does their philosophy mean? And basically, I think it came down to sort of three things they did. One was they put out a regulation on price transparency, which was, I think, fairly significant and still could be significant over time. They put out this regulation related to health reimbursement arrangements, in particular, the ability of smaller businesses to use contributions toward individual coverage as a way of providing insurance to their workers, so-called individual coverage HRAs. That's still small in terms of its take-up around the country, but it could potentially be bigger over time. And then they put out a very long document that sort of outlined a competitive approach to trying to bring down costs. And it's got a whole bunch of ideas in it, some of them realistic, some of them not so much, but had a sort of a vision associated with it. President Biden gets elected, though, a year ago, and obviously at the very top, I think they just have a very different orientation, but a little bit of overlap. So their orientation, I think, generally is that that they believe cost control is really going to come about only through more regulatory control. So I don't think they're going to be real big believers in a competitive approach to cost control. Now, having said that, that doesn't mean they're against the price transparency approach of the Trump administration. And so far, they've stuck with it, which to my mind, I know this industry has some troubles with how it's being implemented, but to my mind, there's some promise there for better things to come if implemented right. But overall, I think President Biden will try to push for more regulatory control over costs over time. And candidly, it looks like they can't get much of that through the Congress because it's so evenly divided. So except for a little bit on prescription drugs, that kind of a philosophy probably won't get enacted in wholesale form. But once whatever happens with this big bill they're working on is completed, I'd expect over the next couple years a lot of administrative action in that general direction I just outlined of more regulatory control of pricing and costs, however they can do that through the CMS and other HHS levers. So that was, I think I went over my very small allotment of time, but I'll stop there.
You did great. Ovik?
My name is Ovik Roy. As Jim mentioned, I run a think tank here in Austin, Texas called the Foundation for Research on Equal Opportunity. We work on how to deploy private sector innovation and free enterprise to help Americans on the bottom half of the economic ladder. And one thing we're known for is our work in healthcare reform, where our general take is we can achieve universal coverage using private insurance and private markets and competition. I think that Jim, by the way, I really appreciate the opportunity to come to this conference because it's a 5-block commute from my office down Fifth Street. So thank you for that, Jim and Jamie. I thought Jim laid out the land in terms of like what have been the policy developments in the last several years. Here's how I would describe the landscape in terms of what's happening in the near to mid future. The frustration that Americans have about the cost of healthcare, of course, it only gets worse over time, but I believe we've reached a tipping point. We're at a point now where the average American household sends more of their income to the hospital industry than it sends to the Internal Revenue Service. The average household makes about $65,000 a year. About 13.7% of their income that's their effective tax rate, goes to the IRS. 18% goes to the hospital industry, just the hospital industry. And that's not merely out-of-pocket expenditure. That's the share of your insurance premium that goes to the hospital sector, the share of your Medicare, FICA taxes, et cetera, that goes to the hospital industry. You put it all together, it's 18%. And again, that's just the hospital industry, right? That is not sustainable. I would argue that that's a tipping point. When people are sending more of their paychecks to the healthcare sector in general, to all of you, obviously you're the messenger more than the recipient of the funds over the supply chain of those dollars, but that's not tenable, right? And it's not just tenable in an intellectual sense, you're seeing it in public survey data. So as you all know, Democrats have been pushing the big solution other than Medicare for All is the public option. 80% of registered Democratic voters support a public option. What you may not know is 56% of Republican registered voters support a public option. 68% of the electorate overall supports a public option. That gives you a sense of how frustrated people are. And from the point of view of the consumer, employer-sponsored health insurance is a form of single-payer health care, right? You didn't choose the insurer. That health insurance card was handed to you by an HR bureaucrat who works above you. You have very little choice. I mean, of course, yes, in some places you got a little bit more of a cafeteria approach, blah, blah, blah. But for the typical worker, they don't have that choice, right? So when you approach that individual and say, would you rather have 2 choices or 1? And that second choice is going to be less expensive. Workers are going to say yes, right? That's just common sense. And so for those of you who don't want that policy outcome, it obviously is incumbent on you and us to devise other approaches to reducing the cost of healthcare. And what we would argue is that the way to do it is to learn from what we do well in Medicare Advantage. Bring the learning from Medicare Advantage to the rest of the market, right? The individual market is supposed to be kind of like MA, but doesn't really work that way in reality. Our friends, the Blues, often dominate the individual market, and a lot of the for-profit guys are not playing in it to the same degree, depending on the market, obviously. And the employer market, the HRA rule that Jim mentioned, I think is a very interesting approach. I know we're going to have a session on that tomorrow, and I look forward to learning from the panelists there about it. But like that, I think that's something that we can build on and do more with to give workers the choice of plan and let the employer still preserve the tax break, but let the worker have more sovereignty over their health coverage choices. I think that's one way to drive competition, because the fact is, the dynamic here that's a challenge is, you all, if you're an insurer, if you're a payer, your margin, let's say it's 5% a typical year. Well, what's 5% of a bigger number? A bigger number for you, right? So how much incentive do you really, really, really have to force trend downward? And that's what you're starting to see the frustration about. And so one thing that we worked some members of Congress on is that who've reached out to us and said, if you don't want a public option, what do you want instead? And the end result is something that's called the Fair Care Act. It's a bill that's been introduced in the House and the Senate. And it does a lot of different things, which we can get into to whatever degree people are interested. You can also read about it on our website. But one of the key things it does is it tries to, the bumper sticker would be Medicare Advantage for all, right? Medicare Advantage is continuing to take more share. I know Austin is doing a lot of research in this area. And there's a lot to learn from how Medicare Advantage is successfully competing with a fee-for-service and bringing that to the rest of the market. Because that's kind of a market where there is a public option, fee-for-service Medicare, and yet the private sector is generally winning that competition. So maybe with that, I'll tee it off for Austin.
Yeah, I was going to mention and kind of follow on your Medicare Advantage idea of just learning from it, and I should back up and say something about myself, which is that I am a researcher. I run a research organization at the VA, but I also do research on grant-funded research at Harvard and BU in the Boston area. And I actually grew up really loving science. I studied physics and engineering as an undergrad and in graduate school. So I came to healthcare and health economics later. So I really care about research, which I'll come back to. But when I think about health policy and zooming way, way, way out, I was actually thinking about this on the flight here, and I made a little list on my phone. I'm not texting. I'm actually just looking at my list. And if you think about the issues that we're talking about today, I was just kind of rattling off the top of my head. What are some of the issues that are coming up? We've got issues about the uninsured, access to care, certainly drug prices and overall prices and cost in general. Those are always issues. Payment rates, their level and their relative across services and sites of care, administrative complexity and cost, quality and safety, consolidation, various dimensions of health equity, racial, ethnic, rural, complex chronic conditions, how you address all those. We have an aging population. Public versus private coverage is certainly an issue, and there's like many more. But when you think about all these issues, and I'm sure you're thinking of 5 I didn't even mention, and then you go back 10 years or even 20, we were talking about very much the same things. These issues are perennial, even though we have, we're told we had, and it's true, we've had like the biggest health reform in a generation just, 10 years ago. So why isn't everything solved? And, of course, it's now just become too big a thing to kind of tackle in one piece of legislation. So I sort of am more in the camp that we are going to have to learn from other programs and make tweaks over time. But that's not to say that nothing has changed, just nothing, that we haven't shaken the entire system, which may be a very good thing, frankly. But what I will say that I am seeing now more than before is a much greater focus on care value. And you can put value in quotes because what does it mean and how you measure it is certainly a very big deal. At the end of the day, usually what, I borrowed this from Mike Chernow, health economist at Harvard, usually what value means when people are talking about it means we're going to pay you less. So, but I mean, that's not what they intend to say, but that is the ultimate outcome is oftentimes the easiest thing to do is just get more value by paying less. It's really hard to improve quality, and I'm sure you all know that. But there is more focus on it. So that's, no big home runs, but we're taking more at-bats, that's for sure. I think there's a much greater understanding broadly about the role of prices, and especially in consolidation. That's something, we've known for decades, but I just think there's been more research and more discussion of it, and it's becoming greater focus. The Biden administration is trying to focus on it. What's to be done is complex, but that's clearly part of the cost problem and issue. There's obviously a lot of attention on drug prices, and there's spreading awakening to equity and the role of structural racism. It's been with us for centuries, but it's about time we're finally focusing on it and relating some of the structural ways racism plays across institutions and across people's lives that actually affect health, and trying to address that is certainly something we should be doing. So what's my bottom line is that the timescales for substantial change are incredibly long. Administrations come and go, 4 to 8 years. It's probably too fast to do a lot of things we're trying to do. So some things get started, some things get continued, a lot of things get killed, and we just kind of cycle around. Because I'm a researcher, I'll just say this once, but I have to say it. We always say more research needed, and you probably knew it was coming from me. But I really do think that as we do try to implement change, and just as Ovik was saying, we need to invest in studying what we're changing. We need to learn from what we're doing. It's not enough to do something, but you need to learn from it. If it's working, you need to expand it. If it's not working, you need to kill it or reform it. And we just don't do enough of that evaluation work. We don't spend enough on it, and we don't listen to it when we do it. So that's, if I'm an advocate for anything, it's that.
Well, thank you, gentlemen. You've done a great job in sort of talking about sort of what's happening in healthcare reform today from 3 different viewpoints. Let's shift for a minute and talk about what we think is going to happen in the future from here. And I'll pose this question to the group. What seems different about today, in your view? The readiness, the solutions, are we likely at a point where we can actually make a difference? It seems like a lot's going on, a lot of changes in the air. There seems like there's an expectancy of that. The legislature's changing things significantly. There's a level of readiness right now, certainly, but are we being overly optimistic about the promise of that change and what will actually happen moving forward?
Well, go ahead, Jim. I don't know if you're sighing or you have something to say.
Well, since you guys didn't say anything, I figured someone had to fill the void. I don't know, So, well, I'll just say it this way. I think I'm not sure we're ready for solutions that are required here. That fundamentally, the problem in U.S. healthcare is that there's been no systematic mechanism put in to discipline the system more across the board. And you see, it's going to have to be either one of 2 basic directions, really. You have to do it like other advanced economies do it and really regulate it, and regulate it in a more serious way than we do in the United States. Or you have to have some approach that allows choices to be made based on people trying to save their own money a little bit, based on price signals. So you have to have some kind of market mechanism, or you're going to have to regulate it, one or the other. And of course, the United States, we kind of do both of them sort of halfway, or maybe a third of the way, and don't go all the way because it pinches and is quite uncomfortable, and there's a lot of disagreement about it. When I think about it in those terms, and I started by saying the Biden administration, I think, wants to be on one side of this. I think they would like to regulate this more and try to control the costs that Ovik's talked about with more regulation. The problem is they can't really kind of find their way toward how to do that politically. They don't have a clear path for it to do it. And so I think, and honestly, the president hasn't really campaigned that strongly on it. And so they're really, instead of doing that, the focus of what they're up to at the moment is just subsidizing people more into the costs that already exist. So if you look at the bill that may pass in the next month, I mean, its main thrust really is to just try to absolutely increase the subsidization of services and not really to control the costs. In fact, very likely some of the services will go up in costs and price because of the heavy subsidization. So is there, are we going to make a big difference on the big question, which is how to discipline the system more? I'm a little bit, I don't see a path forward at the moment. Now, one last caveat on this point is that at the state level, I've seen one state do one thing that looks like it might have some real bite to it, which is why it may not happen, which is the state of Nevada. So they did enact a public option, and it had the two pieces of a public option that really would pinch if they stick to it. First one being that they basically force their industry in that state, some of you may be in cross-state in the part of that market, they're going to force the insurance industry to participate. So if you're a Medicaid plan or you're serving the state employee system, you have to participate. Similarly, if you're a hospital serving Medicaid or anybody in the state public employee system, you also have to participate, and so do the physicians. So they've kind of done the double mandate. The insurers have to be in it, and the providers have to be in it. And then they say, and by the way, you're going to cost, without telling, of course, they don't tell you how you're going to do it, but it's all going to cost, I think, 5% at the beginning, going up to 15% less. So it's sort of like a forcing, just a forcing mechanism is all it is. Now, if they follow through on it, that'll have some effect. But of course, it's got everybody up in arms in Nevada. So I would just say that that's the kind of conversation we're headed toward around the country, probably in a bigger way.
I'm more optimistic. I wouldn't say I'm optimistic in the sort of we're going to win optimism, but I'm more optimistic than Jim. And I'd say that the reasons why are severalfold. First, on drug pricing, which, as you know, is a meaningful part of particularly non-elderly premium claims or claims payments, there is movement on the Dem side, right? They did have this agreement between the House and the Senate on a drug pricing bill that would negotiate the prices of a very small category of drugs to start out, basically drugs that are more than 8 to 12 years old, that are off patent, or at least the composition of matter patent is expired. Things like Humira and other sort of big ticket items. They obviously hope that's the camel's nose under the tent kind of a thing, but they're going to start with those big ticket drugs, which are a significant part of spending, and try to expand from there. And that's, even though that was itself a very controversial reform, if they get it through, and they may not because it's done in the reconciliation bill, and who knows if that can actually get through reconciliation, and what Manchin and Sinema think, blah, blah, blah. But there is work on drug pricing on the Democratic side. Obviously, the Republicans in general are against us, not all. And that's moving forward. I think that the thing about drug pricing that makes it somewhat unique is that the political left has always historically been hostile to for-profit healthcare and private sector healthcare. And so the pharmaceutical industry is for-profit. That sort of ideologically is something that creates a target for the pharmaceutical industry in a way that the hospital industry is 3/4 nonprofit, right? So there's this kind of assumption that, well, if you're Sutter Health and you're nonprofit, you must be on the good guys, right? Even though you're the monopoly in Northern California, for example. And so that is the thing that is, I think, starting to change for all the reasons I mentioned before. The costs are continuing to rise. And yes, there is a lot of resistance. There's a lot of political power that the hospital and drug industries have in Congress and in state governments. But it is starting to change. There's the Hospital Competition Act, which was introduced by Jim Banks, a congressman from Indiana who runs the Republican Study Group, which is a large Republican policy caucus in the House. That bill is pretty robust. Basically, it says this: if the market concentration in a particular geographic area has gone above a certain very high threshold, and you're in a metropolitan area, so not rural. Rural is exempted. Then you basically have to accept the median Medicare Advantage rate in your community from commercial payers. And that means you can be a regulated utility, you can stay a regional monopoly, and you can accept the MA rate, or you can divest that 27 hospital system into smaller bits, get under the market concentration threshold, and then charge whatever you want. So it's kind of like auto antitrust. Now, people like Jim don't like this idea. He and I have had long conversations about it because he thinks Medicare has too much influence on pricing as it is. But if you don't want a public option and you need to get to 60 votes in the Senate, these are the kinds of ideas that I think technically may get you there, right? Because you may be able to get 60 votes between the Dems and the Republicans for ideas of that kind. So that's why I think we're starting to get to a point where the combination of the intolerability of the cost problem for consumers, not so much the deficit piece of it, because nobody cares about the deficit anymore. That's a whole other topic. But consumers care about what they're paying for insurance, and they care about their deductibles, and they care about their out-of-pocket costs. That's driving the conversation. And so for the people who are sort of flinch at the public option, some of these ideas, I think, are where we'll end up landing.
Well, I'll cards on the table. I'm a pessimist. I mean, I don't think things are going to change significantly, except on very long timescales. On the other hand, I recognize that we need optimists like Avik and others. You know, otherwise nothing gets done. Like, nobody, and that's why I'm not, trying to get policy passed. I'm just studying things. But if I was trying to actually get stuff done, I'd have to say, hey, people, this is going to work. Here's how it's going to work. I assure you it's going to work, and trust me, it's going to work, and really be inspiring. But that's not my line of work. I'm just not that inspiring. So I can remain a pessimist, and I believe in incremental change. That I think there will be changes, and the nose under the camel's tent is a real thing. So I'm willing to bet someday I'll be wrong, and that nose will, rip open the tent, and we'll have a big breakthrough on something or other. But in general, my first order guess on things is like, well, next year will be just like this year.
Let's hope not.
Well, yeah.
Well, thanks for those comments. Let's throw something your way that's more preferential. So you've talked a little bit about what will happen or what's likely going to happen in the future. Let's talk about what you think ought to happen or what should happen, and give you a little more latitude in your thought process. Payers don't like public options. You talked about needing to work. If you don't want a public option, it's got to be more affordable. Lots of work going on out there with member experience and digital interface and virtual primary care and that whole program that is needed. And yet affordability continues to be elusive. And so give us your thoughts on what we should be doing and what we must be doing from your viewpoint if we're going to move this forward and do it in a productive and effective way.
Starting down here?
Yeah, let's start at the end.
I mentioned it earlier, but I think one of the major things on affordability is to work on the consolidation issue. I'm thinking of big hospital systems that dominate regions, sometimes most of whole states, sometimes they're national. The prices are just way above, not just Medicare, but not even to say that Medicare is the right benchmark, but way above some of the other hospitals that do provide the same care. So I think consolidation is definitely a place to look. I do think patient experience is extremely important, and that's both the quality of care, which is, again, these aren't easy problems to solve, but super important, but just overall their experience. And I actually think we've learned a few things during this pandemic that actually is helpful. I mean, I think patients like telemedicine, and we're seeing a lot more of it. To the extent we can continue that, I think patients would appreciate it. I'm among them. I love telemedicine. I'm doing all my visits that way that I can, and it's fantastic. That's not necessarily going to help on the overall cost. We could get into that, but I do think patients expect it nowadays, and it's a way to make the system work better for them. Price transparency is another thing like that. I think patients and consumers in general should expect and deserve price transparency. Now I'm talking about, when I talk about the price transparency that patients deserve, I'm talking about the prices that they are going to pay. I don't think a patient who has insurance should care at all what the bottom line cost to the hospital is, or to the insurer rather, of their cost of care, of their episode of care. If the insurer is picking up 80-90% of that, that's between the insurer and the hospital as far as I'm concerned. I think a patient should know, what am I going to pay going in, or at least a reasonable estimate. We all understand things change. So those are 3 areas that I think I would love to see action on. I think would make a difference in patients' lives, and we could make some progress on costs in the consolidation area.
Well, I mentioned at the outset, our broader vision of universal coverage through private insurance, and we do an annual survey every year called the World Index of Healthcare Innovation, where we rank the richest 31 countries in the world with a population over 5 million by a bunch of metrics, including quality, affordability, choice, scientific innovation, science and technology, fiscal sustainability. And the U.S. ranked 6th out of 31 because it did really well on innovation. A lot of Nobel Prize, a lot of R&D, but we were second to last on fiscal sustainability, because not only is our system expensive for consumers, it's expensive for the government. Our per capita subsidies are the highest in the world, actually. Way higher than the single payer countries or some of the other countries where people say, oh, we can't have that system, we can't afford that, right? They actually spend less per capita on government subsidies for healthcare than we do. So how would you actually, if you look at the countries that have universal private health insurance, countries like Switzerland, the Netherlands, Israel, Ireland, Germany, how does that work? And it works differently in each of those models, but we can learn from a lot of what they do. And Medicare Advantage is a great example of how you could envision a system like that here. And the main thread that I would describe is we're having the wrong conversation about price transparency. So as Austin alluded to, if you make the price of a knee surgery visible to the consumer, once they've crossed their deductible, do they really care? They're not going to care, right? The median actuarial value of an employer group plan is 80% or 88% or whatever it is. They're not going to care. But what we really need is price transparency into what consumers are paying for health insurance. Because if I'm giving this talk or having a conversation like this in a room of relatively ordinary people, and you ask them, raise your hand if you know how much your employer is paying for your health insurance premiums, how much they're taking out of your paycheck for your health insurance, there's three people raise their hands, right? The people who run their own businesses, right? Everyone else, nobody else knows. And that's kind of crazy. And so if we actually had a system like the Swiss do, where there's price transparency around what you pay for insurance, and you reap the rewards if you choose the best value plan that has the best network at the lowest premium with the right deductible and cost sharing for you, then that aligns all the incentives, right? Then insurers are competing for your business on price, not merely just surfing along the 5% margin of trend. And then the consumer is more active and more aware, is actually okay with network design and other things that a lot of people are sort of afraid to get involved in. And you have more accountability for things like hospital monopolies and what they do to premiums. So we need price transparency around how employer-sponsored coverage works. And a couple other things drilling down on that are, one, I think those of you in the issuer-payer community, I get that the fully insured group market is the best market, has the best margins, it's the best business for you, but from a public interest standpoint, it will be a much better and more sustainable private sector insurance system if people are choosing their own insurance plans, whether the insurer is giving them the cash to do that or they're doing it in the non-group market. That is the system that's going to be the most politically and economically sustainable long term. And so there's a lot more we can do. And there's another thing we can do. In the Fair Care Act, one of the things that we have is we require employers to actually send a letter to their workers if you have more than 100 employees saying, here's how much we paid for your insurance last year. And here's how much we paid for your insurance the year before that, and the year before that. And here's how it's trended for the entire time you've worked at this company. And so once people have that just education of, you don't like the fact that Brigham and Women's is no longer in your or Memorial is in your network. The reason we did that is because it reduced your premium by 10%, right? You could start to have those conversations with the workers if the employers and the workers are having a mature adult conversation about healthcare costs. And you can't do that through what we normally think of as price transparency. We have to have price transparency around the 88% of the dollars that are spent through the third party.
Okay, well, I have a lot of crossover with Ovik on how I think about this, but I probably would describe it somewhat differently. Basically, I'd say that if you're not going to go the regulatory approach on cost control, which I actually don't favor, if you want to do it through market incentives, you have to do basically two things across the board. You have to, as somewhat like Ovik has just described, you have to structure the market so that when people buy into their health plan through Medicare, through the employer-sponsored system in particular, those two are the biggest and most influential pathways into coverage and into care provision. You need to change both of them so that on the margins, someone who buys into a more expensive plan sees the full cost of that premium very clearly when they make the choice to do so. It's called premium support, and it's been vilified, and everybody hates it, and so on and so forth. But that's the premise of it. That's what Ovik just described. And you have to apply it both in Medicare and the employer-sponsored system. Now, you get a lot of employers out there that say, well, I'm doing all these great things, and I'm doing it on, I'm trying this way, and da-da-da-da. All of that's true, and you're selling, I know all of you are selling to a lot of them. The problem is with the employer system, it's a collective action problem. You have to apply this to all of them so that one employer doesn't say, hey, I'm not going to do that because if I do that and I'm tougher on my workers, I'm going to lose good people to another employer because it's part of the compensation package. So you have to have a public policy that applies to the employer system that forces it in this direction of premium support. Now, that's a long conversation about how to design that, but that's basically the idea. Now, there's another part to this, which take that knee replacement idea. Let's assume that plans also said, when you buy a full episode of care that's understood in advance you're going to need, you can save a lot of money if you pick a lower cost provider. So on price transparency, the next step really is standardization and full episodes of care. So you say to the provider community, they'll hate this, by the way. And all of this is premised on the idea that you have to force competition in ways where the suppliers realize they need to lower their price to gain market share. They don't like that. They don't want that. They will fight it. That's absolutely the only way to get this thing under control through a market, where people can gain by lowering their price, okay? So on the provider side, let's say you had knee replacements and you said anybody who chose for a full episode of care, an organization of providers that offered it for 20% below the market rate gets to keep 10% of that, or half of that. Suddenly, even though they've crossed their deductible, they have a real incentive to get the, if it's high value and they're not going to some place they feel like is going to give them poor quality care, they may have an incentive to take a look at that, right? So on the provider side, you also need price competition, including when a consumer might be involved, okay? Now, this is a small subset. Not everything can be done this way, but it's still significant, it still have an effect. And about maybe 30-40% of healthcare is scheduled, you can schedule it, you know in advance you might need it, you can do a full episode of care, you can price it. There's a lot of healthcare that's not that, because someone's sick and you're not sure what the course of their treatment is going to be. But so again, to summarize, premium support and provider competition at the point of the price that the consumer has to pay, and they get to save money by picking a lower price plan or lower price provider. If you want a market instead of regulation, that's basically what you got to do.
Well, we appreciate those comments. Sounds like we need to maybe rethink structurally the whole premise of group insurance, and then how do we deal with on a competitive way some of these large systems that have bound together for the purpose of preserving price, making it more attractive to them to win if prices go down.
The one thing I'd add, Jim, is that the one way to save the group market, in a sense, is if the Trump price transparency regulations really start to take hold and the payer-provider negotiated rates become a publicly accessible data. And the reason why is that then if you're an employer you're going to have third-party tools that scrape all that data
Agreed.
and allow you to hold your carriers accountable for whether they're negotiating a good deal for you or not. And that may create a lot more competition among the payers to get those prices down.
I'm going to try to be the even-keeled moderator and not get involved in the discussion, but
That's tempting.
On the other side of the table from the providers.
and on the other hand, let's talk a little bit about transparency. Let's talk a little bit about we've got SB 1264 in the state on sort of the no surprise billing stuff, and then the federal legislation that came in. We're all working hard to try to deal with that. But let's stay on the transparency theme. Now that beginning in July, we'll have to be publishing our rates, and the hospitals have been having to do that since the beginning of the year, although many aren't. They're just choosing rather to pay the fine. And so what happens when that information routinely gets out there and smart people start scraping that information, putting it in usable and understandable form, putting it in the hands of providers, putting it in the hands of employers? What happens there? And as you're thinking about your answers there, I want the audience, I'd like to ask the audience to start thinking about your questions. We're going to have some microphones out for you to kind of weigh in on some of this, but let's talk a little bit about that theme of transparency and the disruptive nature and where you think that might take us.
Yeah, I can jump in, and it just follows on Jim's idea and what he was talking about. You know, if you go to a lower cost provider for an episode of care, you get some money back. And I like this idea a lot, you know, because there's evidence behind it. You know, this is a lot like what CalPERS has done. Many of you may know. It's actually like CalPERS on steroids, because I think CalPERS set a price, and if you go above that, you pay out of pocket. If you go below, you don't get any back. But this goes both ways, and there's no reason not to. And the results for CalPERS with the episodes they've done are really amazing. Not just reducing the cost of CalPERS itself, but actually showing a price reduction in the market, right, for those services. And so there is evidence. This is not just an idea. It's actually been implemented to some extent, and there's evidence on that. The other thing we know from research, and this comes out of work at Yale, is that for routine MRI services, most patients, when they're going for their MRI, usually they're going where their doctor recommends, they drive by something like, on average, 6 other perfectly good MRI locations that would be cheaper on the way to the place that they're going. And if they had only known, and if they were incentivized to take advantage of that, they'd say, hey, let me save myself on gas and on time and get a cheaper price that I get some return on. That makes a lot of sense to me. The only caveat would be, oh, but my doctor said I really got to go over there. So you have to get patients to understand that sometimes the physician may not be the best source or most unbiased source of where to get care. So that's just my 2 cents on
Very
that.
good.
You know, I tore my Achilles a couple years ago playing soccer, and I thought I was going to do this. I'm going to shop for the MRI that's the cheapest, that's within a 15-mile radius of my house. And I thought this was going to be really great, and I was going to be like an informed consumer. And after I filled out literally 9 web pages of incredibly private data about myself to get one quote, and then I did that the second time, and I realized that I'd already gotten into my co-insurance phase. So I'm we're talking if the MRA is $500 versus $200, the savings to me is $30, and I've already spent an hour of my time doing this. I'm for me personally, $30 an hour is not worth it. Now, for some people, it might be, but I gave up because I'm giving away all this information to random people about myself for what? For a quote. So
you made a rational choice.
Yeah, it would be great if we had a GoodRx type thing, a tool that you could say, okay, here's Google Maps and here's all the places and here's what they're charging. Today, you can't get those kinds of quotes because the friction to get the quote is incredibly hard. And this is why the price transparency tools can be really useful. And Jim, if you want to, I would certainly be interested in where you think price transparency could be improved, because that's something that could really, I think, could make a real difference. I think all of us feel that way in different degrees.
Yeah, no, I'm convinced that if you do it right, you could save a lot of money, because people do like to save money if they can. So in Ovic's case, imagine if for Achilles surgery, you told all the providers out there that take care of patients with this condition that they had to have a walk-up price that they posted for taking care of this problem, because it can be, it's painful, don't get me wrong, and there's a certain urgency to it, but it can be scheduled and you can do it. And if you just forced them all to give a walk-up price that was posted publicly and everybody could see it, and then your insurer said, by the way, if you take one of those who's posted a price that's below our median that we're paying in your market, you get 50% of the savings and we get 50% of the savings. Suddenly the friction of, first of all, finding out what it is, getting an all-in price, not just for the MRI, but for the full episode, taking care of the thing, which is really what you want to know. You start to get the incentive. Now, the big hurdle here, what's the hurdle here? The federal government's got to tell these providers that they have to do this. Now, you saw the fight and the fight that's underway over just disclosing what they're doing now, right? And they're posting all kinds of nonsense, and it's hard to figure out. The stories, by the way, about this are fantastic. I mean, you read the Wall Street Journal exposés on these things, and it just shows you the absolute nonsense that they're imposing on the public. And, it's completely insane the way this works today. And so it's ripe for people to come in and say, we're not doing this anymore. You have to price reasonable things that can actually be actionable for the paying public, the insurance industry, as well as the consumers. And, if someone had the guts to make the providers do it, they'll scream bloody murder because they do not want to compete on price. That's absolutely the last thing they want. And so, that should be a signal that that's what we should be doing.
One thing we're making a lot of progress on, I think, and maybe you guys would disagree, is on the concept of site-neutral payment. I don't just mean that in the Medicare context where it's most talked about because of the fiscal implications, but in the commercial market as well. In Indiana, they tried to pass a law. Anthem was behind a lot of it because they're headquartered there, where the claims form, the big problem is the claims form that the hospitals use obfuscates the site of service. So basically the law in Indiana the bill would have required the hospitals to use a claims form that gave detailed geographic information so you could know whether this was in an ambulatory center or in an inpatient setting. And the hospitals went completely nuts, right? They basically blockaded the state capitol, going completely crazy, sending lots of people to say the hospitals are all going to close if this bill passes, this provision passes. And it's just like, if your entire business model is based on lying about where the site of service was, maybe you're in the wrong business, right? And so that's a kind of a subtle reform that I think can actually work because, yes, lobbies are very powerful, blah, 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 blah. But something like that is just so indefensible that I feel like if there's a real grassroots push to just be transparent about the site of service, right, that could make a huge difference.
Great comments. Let's open it up to questions in the audience. I think there's some mics moving about out there. Here's in the middle.
So given the real-world evidence we have of things like reference-based payments combined with shared savings incentives actually driving real value, why, in your opinion, do you think so many employers who can control their own plans have been reluctant to implement reforms like that?
I wish I knew.
Well, I'd say it's a couple of things. One, it's a lot of work, right? Because if you look at the CalPERS experience, you talk to the people who are involved in that, there was an enormous lift in terms of patient education to get the workers or the members to recognize that if they went to this provider over here, they were going to pay that extra amount, or they were going to save, not save the extra amount, but to get the best price. And so that was hurdle number one, is that there's an enormous amount of patient education or worker education that goes into it. And most employers just don't have the bandwidth to do that. Maybe the largest, the Walmarts of the world that are really trying to push the envelope, they can try to think about this more, but that's been a hurdle. Another piece of the hurdle is that it really works well, this CalPERS style model, in elective surgeries where you really can choose where you get the service, right? MRIs. But it's not going to work for air ambulances, right? It's not going to work for if you have a stroke. So it's not like every single type of healthcare service is amenable to this model.
There's a shared action problem too, collective action problem, is that like I said during the previous comments, that you have to change the whole employer system kind of generally so they all have an incentive to lower their premiums together. Because if not, then some of them are, it looks like they have a richer benefit on one side as opposed to another, and people feel like it's a way of trying to attract workers. And so a lot of employers are reluctant to get into this because they view it as, this is a good news, and honestly, this could be good news, but they don't necessarily always view it that way. Sometimes they say, well, it looks like we're putting restrictions on our benefit package, and some people don't like that.
Employers generally don't have an incentive. There's this myth that employers have a huge incentive to reduce the cost of their health care. Every CEO thinks that he has the incentive to reduce the cost of his health care, but he has a much more powerful incentive to not make his workers mad and leave the company, right? And that second incentive is far more powerful than the first, especially if you're in a competitive labor market like we are now. And so if you look at the track record, look at the evidence, employer, the price that employers pay for healthcare is going like this, and Medicare and Medicaid are going like this, adjusted for inflation. That tells us that employers are not prioritizing reducing the cost of healthcare because employee retention is more important to them.
Other questions?
Oh, okay, sure. Hi. The mention of kind of geographical location and how much a provider charges for a procedure, I'm not, it's, I hate to say because I'm touting the product of the company I work for, but this is available. It's CMS data, and we can tell you not only geographical location and price that is charged, but how much CMS agrees to pay, which also shows what is the provider willing to accept. So the provider might charge 7 times the amount, or sometimes just a little over. One time they're not all that high, but either way, it tells you what they're willing to accept. In addition to that, you'll find in the geographic locations you mentioned, you may pass by 4 providers on the way to one that does do the job for less. Not only that, our providers are ranked by how many times a year they do that procedure. So you'll find some, you find the most expensive cost per procedure and you think, wow, this guy must be a pro. You find out they're way down on the list and how often they actually do the procedure. Sometimes the most often procedure done, or I'm sorry, a provider that does the procedure the most does not charge the most. They might charge a better amount, and guess what? If that guy's doing it a few hundred times a year, they're probably much better than the guy doing it 11 times per year. So this information is available. It's public information, well, it's CMS data. We have it in our system put in a user-friendly format. I'd love, it's Denniston data, provider ranking system. I'm not only saying this to advertise for myself, but to say that it is available, and I'd like to hear any comments you guys have on it. Thank you.
Well, you should talk to the payers because the payers and the employers on the commercial side don't have the visibility into a lot of these shenanigans. But sounds like it's a very interesting company.
Yeah, I mean, I think it's great to have that from CMS data, but of course the CMS data doesn't include the commercial pricing system at all. So, that's still invisible to most people. And the price transparency rules that have come out, I mean, the reporting on it has been really interesting. And I every time a story comes out, I love reading it because they're so funny about just the complete irrationality of that and the lengths to which the providers have gone to try to hide some of their irrationality. And then, as soon as they get into a story, the next day they say, oh yeah, that was a mistake. We meant to disclose, the whole thing and, blah, blah, blah. It's kind of comical, to be honest with you.
Thank you. Thank you. Other questions? One over here to the right.
So thank you very much. So this is very enlightening discussion. So I'm a physician, so I'm thinking about the role of particularly primary care physicians to be advocate for price transparency for their patients when it comes to some elective procedures or preference sensitive conditions. And my understanding is that for most physicians that are part of a large health system or mid-sized groups, Some of this price discussion information and communicate that to patients, it's really not a big priority because they themselves struggle about understanding the terminology. It's a new lexicon, and there may not be enough incentives for their patients to be price sensitive with regard to quality and cost of care. So what are your thoughts about sort of engaging with the frontline primary care physicians about being a strong advocate for price transparency for their patients?
Yeah, I mean, there's definitely a big difference between the employed physician versus the independents, right? So if you're employed, I mean, this is where the ACO model, in my view, always had a fatal flaw, which is if the hospital systems are buying up the primary care practice, they're doing that to control the referral volume and charge more, right? That's there's been a lot of evidence of that in the research literature. So that's been a problem. I'm more hopeful that if the physician is not in that situation where they're forced or pressured to steer the patients to a particular provider, that they're with price transparency, particularly the payer-provider negotiated rates becoming public, third-party tools, technology will become available to practitioners to be able to help their patients find the most cost-effective provider given their payer status. So I'm hopeful that on the independent side can be solved. The vertical consolidation, though, between the physicians and the hospitals is more dangerous.
I believe we've got time for one more question.
There's a mic on that side if you want.
I need a hand. Where's the hand?
Nobody?
Well, if there's no more questions, then let's give a round to our panel of experts.